Today, I am going to share with you some knowledge about facial nerve and its disorders. Before that, I might in brief introduce myself to you. I am Dr. Air Commodore Aditya Bhargava, retired from Indian Air Force about 5 years back as consultant in ENT. And now I'm working as senior prof and HOD ENT at Pandit Bhagavad Dayal Sharma PGIMS Rohtak. As you know, that facial nerve is the seventh cranial nerve. It is also known as queen of the face because of its vast supply to the face and the muscles of facial expression. It's a mixed nerve. It is motor, secretomotor, as well as sensory, cutaneous sensory, as well as the taste fibers it carries. It is, as I mentioned, it is closely associated with ear and face. And because it is commonly paralyzed, it becomes a very interesting thing for an otolaryngologist. Now, to recapitulate a little bit of anatomy and its function, I suggest that this, whatever I am showing on the slides, is just a framework. You can read the detailed anatomy by the pertinent books. To start with, the nucleus of facial nerve, that is the motor nucleus, lies in the pons. And the upper part of the nucleus is bilaterally innervated from corticonuclear fibers, whereas the lower part of the nucleus is contralaterally depicted. That's why in the supranuclear type of facial nerve paralysis, forehead wrinkles are spared, which is a very, very common and distinguishing test for distinguishing between supranuclear as well as the infranuclear facial nerve paralysis. Now, facial nerve has got a long course. These are whatever dimensions I have mentioned here is taken from the books. These are all approximate. Different books mention different dimensions. The first part is the cisternal part, that is from the pons, and it goes to the intratemporal part, which is further divided into meatal part, that is inside the internal acoustic meatus, then the labyrinthine part, which is above the oval window, and then the tympanic part, which is the horizontal part, and the mastoid part. And then it comes out of the skull from the stylomastoid foramen, and inside the body of the parotid gland, it divides into 5 terminal branches. And the surgical anatomy and the surgical importance of this is that this division divides the parotid gland itself into a superficial lobe and the deep lobe. Again, same thing, that this is facial nerve anatomy and its course, that you can see that it has got intracranial course and there are branches. Cerebropontine angle, it comes out, goes into the internal acoustic meatus, where the sensory root, also known as nervus intermedius joins. Then it goes to the geniculate ganglion, some fibers synapse there and carry on. After coming out of the geniculate ganglion, it is joined by the greater superficial petrosal nerve. Now, conventionally, we are knowing greater superficial petrosal nerve as GSP nerve. But nowadays, the newer anatomy books have deleted the superficial word. The reason not known, it is known as greater petrosal nerve. Then it travels along the medial wall of the tympanic middle ear cavity, gives the branch to stapedius, which goes to the stapedius muscle, a cauda tympani branch. This passes anteriorly across the tympanic membrane, where you can find, while you are raising the tympanomeatal flap in doing middle ear surgeries, you can see a band-like structure. Here I always mention that any band-like structure after you are raising the tympanomeatal flap is cauda tympani nerve until proved otherwise. So please try to preserve this band-like structure in all your surgeries. Then cauda tympani, this passes anteriorly across tympanic membrane into intertemporal fossa, where it joins the lingual nerve, and through the submandibular ganglion, it supplies the submandibular and sublingual glands. Then the facial nerve emerges out of the stylomastoid foramen. Now here are the 5 terminal branches. First is the temporal branch, second the zygomatic branch, buccal branch, marginal mandibular branch, very, very important, because this branch in parotid surgery is to be preserved. Otherwise, person will lose the facial beauty. Then there is a cervical branch, last one. GSP nerve, now I will tell you about the fibers of the nerve. GSP nerve has got secretomotor fibers for lacrimal, palate, and nasal glands. The GSP nerve is joined by the deep petrosal nerve, that is nerve which arises from the sympathetic plexus, and then it becomes the Vidian nerve, goes to the submandibular ganglion or pterygopalatine ganglion, and then it supplies the lacrimal, palatal, and nasal gland. There is a nerve to stapedius, chorda tympani I mentioned. It carries secretomotor fibers to submandibular, sublingual glands, and also carries taste sensation from the anterior 2/3 of the tongue through lingual nerve. Posterior auricular branch, it supplies the muscles of pinna, occipital belly of occipital frontalis, and then 5 branches after exiting the stylomastoid foramen through parotid gland, then the supply of muscles of facial expressions. Secretomotor fibers, again mentioning for the heck of, because it is very important, to lacrimal and nasopalatine gland through greater superficial petrosal, Vidian nerve, and pterygopalatine ganglion, to submandibular sublingual glands through chorda tympani, submandibular gland, and the lingual nerve. Motor fibers nerve to stapedius, and here the point to be noted, muscles derived from second branchial arch, that is muscles of facial expression, buccinator, platysma, posterior belly of digastric, and stylohead muscles. Sensory fibers, that is the taste sensation, anterior 2/3 of the tongue via chorda tympani. The now posterior canal wall, a portion of the posterior canal wall, nervous intermediate, palate and facial pillars. Because these are the sensory supply, we can see the vesicles on Ramsay-Hunt syndrome. I'll let you know about the Ramsay-Hunt syndrome in subsequent slides. Then there are certain interconnecting fibers, intra as well as extracranial fibers, which communicate with all 3 divisions of the 5th nerve. Now, coming to the disorders of the facial nerve. For the sake of convenience, I have divided into facial palsy, anatomical dehiscence, and the tumors. Our main stress will remain on facial palsy in this talk today. Now, what are the causes of facial paralysis? There are a host of causes. You can see here there are a host of causes mentioned in the book. I think this has been taken, I have taken it from Scott Brown, various books divided into various other things. But what is more important, which are more common, is this one. The Bell's palsy, the commonest, herpes zoster oticus, traumatic, subsequent to the COM, squamosal type, and formation of cholesteatoma, now dehiscence, and the tumors. Facial paralysis can be, according to the severity, whatever is there in facial paralysis, there are 3 types. The severity is there. Neuropyrexia, which is the partial paralysis, which is graded as grade 1. Axonomasis, that is moderate paralysis, that there is a little deep involvement of the facial nerve. Injury to axons are there. It is grade 2, 3, and 4. And neurotomesis, that is complete searing of the facial nerve, grieve injury to the nerve, it is grade 5. Now, how you grade these? It is beyond the scope of this talk, but you can read it through the books. It is given because that you will have to mug it up. How we clinically evaluate a facial nerve paralysis case? There are two ways. There is one complete history and the physical examination, including complete head and neck examination, as well as pertinent neurological examination. According to that, we grade the facial nerve paralysis into according to various systems. The most common is House and Brackman staging system. Again, you can refer it through the books so that you have to learn, you have to mug it up what is grade 1, 2, 3, 4, etc. There is some mention about Gurus and fish classification, which is not very popular. What we follow is this House Brackman staging system. Now, running through the diagnostic tests, first one is topo diagnostic. What is topo diagnostic means? According to the anatomical side, how we locate that what site is there of the facial nerve affection. So there is a Shermer test for doing lacrimation test, stapedial reflex test, electrogustometry, and salivary flow testing. Out of these four tests, this is what we are practicing today. It is very cumbersome for the patient as well as for the doctor and as well the interpretation. Shermer test, electrogustometry, there is instrument is required for doing like these are all theoretical as well as for some carrying out some projects and all. Salivary flow testing, you cannulate the submandibular duct and all those things, which is very cumbersome for the patient. Whereas stapedial reflex is available through tympanometry, you can do, and that gives lot of information. Then second one, which are very important, is electrodiagnostic test. What they do, they evaluate the degree of dysfunction and the assumed prognosis via the viability of the nerve. How much nerve is viable at the time of presentation? That gives us it. So many things depend, whether we are doing surgery, conservative treatment, all depends on electrodiagnostic test along with CT and all those things. Then if the lesions are distal to stylomastoid foramen, there is some method, transcranial magnetic stimulation, which is also not very popular because instrument is very, very expensive and not available in most of the hospitals. Radiology, HRCT of the temporal bone and for the facial nerve paralysis, and MRI for suspected tumors or soft tissue lesions. Now coming to the main thing, that is the Bell's palsy. Bell's palsy is the most common type of lower motor neuron type of facial nerve paralysis. In otolaryngologic practice, about 90% of the cases they come of facial paralysis are of Bell's palsy. So how you define? Now all these words are important. It is idiopathic because cause is not known. However, these are the etiologies available. Lower motor neuron type of seventh nerve palsy. That is to qualify Bell's palsy, we have to rule out everything and then we label it as Bell's palsy. It is, I could have written over here unilateral, but we have seen cases of bilateral Bell's palsy also. So unilateral is not the more important thing. What are the etiologies? There are various viruses which are incriminated for this. Then there is a ischemia of the nerve. Vasa nervosum of the nerve is there and it gets due to viral infections or any other. There is edema inside the canal and which hampers the blood supply, leads to ischemia of the nerve. Then there are autoimmune disorders around. All in all, this remains as idiopathic. Now, how the presentation occurs? It is a sudden onset. Generally, the presentation is that the patient gets up from the bed. He is all right. Male patients, generally, they present that they are doing the shaving. As soon as they are doing the shaving, platysma muscle is involved. And they find that suddenly their eyes is not closing. There is a deviation of the angle of the mouth. There is numbness of the face. That is how it is presented, generally in winter seasons. Mostly, as I already discussed, it is unilateral. There is inability to the closure of the ipsilateral eye, drooling of saliva, and deviation of the angle of the mouth, towards the non-affected side. Asymmetrical face, loss of forehead wrinkle. Ipsilater, supranuclear, it is paired, as I mentioned earlier. This is a very good bedside test. You ask the patient to wrinkle his face. If the wrinkling is spared, then it is supranuclear. If it is wrinklings are absent, it is lower motor neuron type of facial nerve paralysis. Absence of nasolabial fold, that is ipsilateral side. Mentioned earlier, these are the tests we do. More common done are these two tests, nerve conduction test and stapedial reflex test. Bell's palsy, how we arrive to the diagnosis. It is, as I mentioned, it is a diagnosis by exclusion. It is the commonest cause. So first thing should come to your mind, it is a Bell's palsy. Then you exclude other tests by doing other tests and examination, complete otological and head and neck examination, hemogram, ESR, biochemistry, serology, HRCT in selected case where we are deciding when to operate, and electro-diagnostic test and nerve excitability tests. So Bell's palsy, the general treatment is general management, that is reassurance to the patient. Any patient walking with any type of paralysis, first thing that person's come is कि brain में कोई tumor हो गया या brain में कोई hemorrhage हो गया. So we have to reassure that this is an isolated type of paralysis of the nerve of the face, which will take time. Don't give him false hopes that it will improve with your medicines in 2 days time or 5 days time, 7 days time. It will improve over a matter of months, maybe a year. So that sort of reassurance you have to give, but you have to tell the patient that it is not serious. We have to give, if the patient is having some pain or anything, anti-inflammatory analgesics, care of the eye, very important. 2-3 things you have to do. You have to advise the patient to wear goggles while traveling outside, because otherwise there will be chances of exposure keratitis. You have to advise the patient to wear eye pad while sleeping, because eye will remain open. Some proportion of the palpebral fissure will remain open. So it may lead to exposure keratitis again. You have to advise him eye drops to avoid all these things. Maybe you have to advise at night time, you have to advise him or her suitable ophthalmic ointment. Physiotherapy of the face. This I have mentioned here to discuss about it because this is very, very controversial. When there is an active lesion, please, for the sake of God, don't advise the patient a physiotherapy anything between 3 to 4 weeks of the onset of the symptoms, because this will lead to disfiguration, synkinesis, muscle atrophy, fibrosis, lot of things. Advise him or her that the physiotherapy may be required after 3 to 4 weeks. Then there is a medical management. There is strong evidence that steroids are helpful if patients reports within 1 week of onset. Best scenario, if the patient reports within 72 hours, start immediately the steroids. Prednisolone in the dose of 1 milligram per kg per day for first 5 days. If recovery occurs, taper off over next 5 days. If there is no recovery, same dose for another 10 days and taper off in next 5 days. Mug it up. This portion, you mug it up. You must practice this. Antivirals, acyclovir and other antivirals are also tried, are being given in the dosage of 500 milligram, 8 hourly, 4 hourly, depending on the severity of the disease. Then other drugs are like vasodilators. Some people give tablet pentoxifylline, 1 BD, 1 TDS. This doesn't hold any evidence in the books or in the journals. Neurotropic vitamins like B1, B6, B12. These are very good because the number of drugs, this is good for private practitioners because a number of drugs will certainly impress the patient, and I don't think so there is any harm in giving it a trial of these drugs. Then Next thing comes when medical management is not, the patient is not improving. What do we do? When do we do a surgical management? That known as nerve decompression, and we do the master exploration, and I'll let you know when I come to that topic. Then there are complications, incomplete recovery, as I mentioned, exposure keratitis, skin kinesis, mass movement. Then when facial nerve regenerates, it supplies a lot of muscles. It goes to wrong side. Mass movement will occur. Tics and spasms, contractures when we undergo unnecessary, untimely physiotherapy. Crocodile tears and Frey's syndrome. These are two very important things. Crocodile tears, what is crocodile tears is gustatory lacrimation. When the patient is eating, he has got tears flowing out of his ears. Why it is known as crocodile tears? Because it is said, I have not seen it, but it is said when the crocodile eats his prey, he cries, that is, tears are rolling down. On one side, he has killed the animal and eating it, and other side, it is means it is a false tears. That's why it is a saying also, don't shed crocodile tears. Why it happens? Because the nerve impulses which are carrying the taste fibers and which are to be only for the salivary glands, they are going to the lacrimation glands also. That is the lacrimation glands also, they are going. So that is the antidromic impulses are going, which is causing tears. Same is with Frey syndrome. There is a gustatory swelling. Patient is eating, there is sweating on the particular areas of the face. Intense sweating because sweat glands are getting stimulated along with these gustatory, salivary as well as taste fibers. This I have mentioned already. Then second most, not most common, but second of importance is herpes zoster oticus. It is also known as Ramsay-Hunt syndrome. It is the reactivation of some chickenpox type of virus inside the body, which causes herpes zoster oticus as well as ophthalmicus. That is eye involvement through, I mentioned about interconnecting interconnections between fifth and seventh nerve. Here it comes. Association of ophthalmicus. There are vesicular eruptions on the supply of the facial nerve, that is posterior canal wall and adjoining face. Management is antiviral in high doses, 800 milligrams 5 to 6 times a day. Steroids also mentioned in the similar dosage. This is given, and the patient, the recovery is slow and the prognosis is worse than Bell's palsy. Some patient might not even recover fully, but vesicles, of course. But there might be paresthesias and all those things like herpes zoster and any other site of the body. It causes paresthesias and those type of numbness and false pains and all. It can be left over there. Now here comes more important one is the traumatic facial nerve paralysis. Associated polytrauma complicates the thing. There is a case of head injury with multiple fractures. Facial nerve takes the second this thing. Management becomes deferred. Therefore, this becomes a suboptimal management. Why? Because facial nerve detected is later on, and but for us, for otolaryngologists, when we detect is very, very important. RTA and mechanical injuries like head injuries, temporal bone fracture. There are two types, longitudinal as well as transverse. Longitudinal fractures, there is 20% involvement of facial nerve, and in transverse, there is 50% chances of involvement of facial nerve. What are the principles of management? We make our principle on onset and degree of paralysis. Remember this word, IOCP. If it is of immediate onset, complete paralysis, please open up, surgically decompress the facial nerve. IOCP, immediate onset, complete paralysis, open and decompress the nerve. Results are much, much better. Or if neuronography shows more than 90% involvement within 6 days. Then also we open up. In late cases, ENOG is not useful for more than 3 weeks. In that, EMG, that is electromyography, and CT scan dictate no return of facial function on electromyography in 6 to 12 months post injury time. Exploration, removal of bony fragments. If the bony facial nerve is dehiscent or it is lacking, it is this thing, then facial nerve grafting, repair, etc. Surgical methods are done. Iatrogenic facial nerve paralysis. Suppose we are operating for modified radical mastoidectomy or any other ear surgery, we find that facial nerve gets injured or there is a paralysis. Then what are the sites of injury? Distal tympanic segment. Okay, that is the distal tympanic horizontal segment, second genu, and mastoid segment. These are the three segments which are very commonly affected by our surgical procedures. Here, what are the principles of management? Suppose intraoperatively you feel that you have injured the facial nerve. It is recognized. Then re-exploration of all the sites we have mentioned and decompression there and then, because wound is open. Immediate post-operative, patient has come out into the recovery and a few hours you have noticed that there is a facial paralysis. There is no harm in few hours further observation for effects of local anesthesia to wane off. We have given a lot of xylocaine and all. It takes about 6 to 8 hours, 10 hours for the effect to go. Let it go. There is no harm done. Then you can loosen the packs and dressing and see. Again, if it is not recovering, there is a partial paralysis of facial nerve, give him steroids in full dosage, prednisolone or methylprednisolone in full dosage. If the patient progresses into complete paralysis, then exploration of the mastoid. Open up the mastoid and proceed. You may find bony spicules, you may find edema, you may have to, incise the sheath of the facial nerve to decompress the facial nerve. Then other causes of facial nerve which are common, acute otitis media. Sometimes we get the patient with acute otitis media and acute mastoiditis along with facial nerve paralysis. Give cover of antibiotics for 48 hours minimum. 48 hours minimum. Carry out the myringotomy, that is, and with Grome incision, and patient is not improving within 72 hours, you can do the mastoid exploration. In selective cases, only the cortical mastoidectomy is done. Here, what we are going to do is we are going to decompress the mastoid and we are going to little open up the additus so that all the abscess and the pressure is relieved and the patient will have facial nerve may improve. In malignant otitis externa, everybody knows. Hello. Malignant otitis externa, everybody knows that antibiotics is the treatment of choice because this is caused by the pseudomonas in immunocompromised, especially diabetic patient. In this, we give antibiotics and, if available, hyperbaric oxygen therapy. In CSML, that is comosal type, modified radical mastoidectomy and facial nerve decompression, and tumors, especially schwannomas of the tumor, which is very, very rare, we'll have to, excise that portion of the facial nerve and do end-to-end or interlay grafting we have to do. Now, I have come to the conclusions. As you know, the facial nerve is a very vast topic. There are a lot of monograms written, like Otorhinolaryngology Clinics of North America. A full volume is written on facial nerve. I request you to please go through that volume, chapter by chapter. It is given very beautifully. And consult your textbook, maybe Paparella, maybe Scott Brown, or other Satiloff, and so many other books are available. Please go through facial nerve, because in your lifetime you will be dealing with this main cranial nerve, that is one, it is the facial nerve. If we treat the patient accordingly, there are gratifying results, especially in Bell's palsy, the patient improves. It's a multidisciplinary management. Paralysis of facial nerve, it's a multidisciplinary management that is ophthalmological, uh, otolaryngological, neurosurgeons, neurophysicians, all are involved. Physiotherapist is involved, and audiologist is involved. The role of physiotherapy, I mentioned the timing after 4 to 6 weeks of treatment of active disease treatment, then you can go in for physiotherapy, and the physiotherapists, they know their jobs, they do accordingly. Reconstructive surgeries like lid surgery, facial augmentation, slings, Botox, nowadays hardly anybody does it because these are all plastic surgeries. All plastic surgeries, hardly anybody. Jai Hind. Thank you very much.
So, dear trainees, you may type your questions, comments in the chat box.
Yeah. How do I they go to the chat box, sir? Chat box. Okay. Questions and answers. Okay. I'm into the chat box. Is low. HPOT is helpful, sir, in the net tissue in ESG. Can give iron supplements to iron studies. See, somebody has asked about hyperbaric oxygen therapy. You know, I belong to 33 years. I have served in Air Force, and we had a lot of, hyperbaric oxygen therapy used in our aviation training. So we had opened up a clinic also there. So what is hyperbaric oxygen therapy? It is 1.5 time atmosphere of the 90% of oxygen plus 10% of, sorry, 10% of the air. So how does it help? Hyperbaric oxygen, because it is at 1.5 atmosphere, it, opens up the channels, blood vessel. Idea is to improve the ischemia. That's why it is used in idiopathic, unilateral or idiopathic sudden SNHL also, in Berger's disease, peripheral vascular diseases. It helps. So it is being given. That is the only question I've got. Do iron studies if TICV normal can give these supplements? See, iron supplements in facial nerve paralysis, there is no report. I have not read it anywhere. So I don't have any knowledge about the iron supplements can be given. Because iron deficiency anemia that can cause facial paralysis per se is very, very rare. Sir, why it is called when etiology can be viral or ischemic? There is a question. It is written why it is called idiopathic when the etiology can be viral or ischemic. See, we have incriminated so many viruses for this. So what we say is that solely saying that particular virus is there, like what we do is know is coronavirus disease caused by this virus. But facial nerve paralysis till date, nobody has said. They say that it can be caused by adenovirus, this can be caused by chickenpox virus, this can be caused by respiratory syncytial virus. So that's why it is not. You know why it is known as idiopathic? Because there is so many idiots, they can't decide what is the etiology of the disease. Any other question? See, while I'm waiting for the question, my request again is that this topic has been very vast. I have, erased out or I have missed out on certain things like electrodiagnostic type, which is a topic on its own. You have to understand, you have to see the test being done. That's how you understand. If in your particular hospital, these tests are available, generally these are available with neurophysicians nowadays, or maybe physiology department. You can go have a class over there, read it and see how it happens. You can take your facial nerve paralysis patient and go there and see how it happens. Similarly, CT, radiology, MRI, and all those things, you have to see the films. You have to locate the facial nerve first. What we do is we see the MRIs and CTs of facial nerve paralysis. No, you see first the facial nerve normal anatomy. Go to the radiology department, go after the concerned interventional or otherwise radiologist, ask him where is the facial nerve. Then only you can see the abnormal facial nerve. What is normal, what is abnormality. That is how you can. Any other questions? Hello.
Yes, sir.
I think, hi,
There's
Mr.
one more
Manish.
question from Dr. Yuvraj.
Okay. Can I hear this question or it is on the chat box? It is not there in the chat. Only one question is to show the slide before Bell's palsy. Slides before Bell's. It is very difficult to show me again how you repeat the initial slides. Somebody is asking for repetition of initial slides, which is difficult
Move to
for
the
me.
next question, sir.
Which is the best antiviral for herpes zoster oticus? Yeah, the best antiviral still antiviral is acyclovir. Acyclovir is time tested. There are newer available like retrocyclovir and others are available, but acyclovir is time tested. It is of the same this thing and it is even cheaper than other one. If post surgery, if facial paralysis need to given and the need for surgery, grade 1 and 2. See, post surgery facial paralysis, we have to give steroids. As I mentioned, that initial period for about 5 to 7 days, you can wait because it's a partial paralysis. If it is a partial paralysis, you can wait, give steroids. If it recovers well and good, it progresses to complete paralysis, please open up. Second thing is physiotherapy timing. Time and again, I am mentioning that not in the active cases, 4 to 6 after the treatment is commenced or total duration of 4 to 6 weeks of the treatment, then start the physiotherapy. Any grade, there is no problem. Any grade you can give physiotherapy. It is always better to give physiotherapy. Initial slide repetition, dear, it is very difficult for me because I have to go again to the share slide, which has been grayed out. You please show the slides, Bell's palsy, first. See, you can get my email address from the organizers or I will share the slides with you. I've got no problem. You can personally write to me. I'll certainly share the slides. Like some question is regarding vitamin C. See, vitamin C again, it's a non-specific treatment. Specificity only is in scurvy when there is a vitamin C deficiency, or they say that it has got membrane stabilizing effect in common cold and cough. But per se as a specific treatment, no. Specific treatment, neurotropic vitamin B1, B6, B12 I mentioned, that also is under, a lot of this thing. I think I have addressed all the questions. Mr. Manish?
Sir, there is one more question.
It is one question is how to diagnose versus Bell's palsy. See, Melkerson syndrome and as well as Bell's palsy, both, both are idiopathic, lower motor neuron type of paralysis. Only thing is that there are certain immunological tests like IgE, IgM and all specifically for Melkerson syndrome. That if carried out, uh, then you can only diagnose, you can distinguish between Melkerson syndrome and Bell's. However, the treatment for both the remains the same. Melkerson syndrome is very rare. So please don't go after Melkerson syndrome unless you've got a very good and strong reason to go after it. Otherwise, Bell's palsy is like Melkerson syndrome. RH syndrome means Ramsay Hunt syndrome. Herpes zoster oticus as well as ophthalmicus. It's a well-known terminology nowadays. It is mentioned in books. RH syndrome, Ramsay-Hunt syndrome, or RHS also it is known as book written in the books. Any other questions, sir? I can't see any more question.
So you have covered all the questions. Thank you very much for the presentation, and thank you very much
Pleasure is mine.
for joining us.
Always a teacher gets pleased if the students get satisfied. I don't know what is the level of satisfaction through this thing, but you can tell them if they feel like they can contact me personally. I will certainly reply to their queries, and I will even share the presentation. There is no problem. This is not a copyright of me. This is copyright of Saraswati. Okay. So Goddess Saraswati is always with everybody, whoever is studying and whosoever is teaching. So thank you very much and have a good day. Can I
Thank you,
leave
sir.
now?
Thank you, sir.
I can
Yes,
leave?
sir.
Leave you. Okay.